Hello again, everybody. We are going to talk about an extremely pertinent topic here, and that is constipation. Now, issues with pooping are probably one of the most common things that a GI will see, and certainly it's going to present in just the general primary care office. People, unlike with diarrhea, people often with constipation do not come to the ER. They come to the clinic. And step 2 and 3 have a huge emphasis on ambulatory medicine, meaning outpatient medicine, which makes sense because that's where we spend a lot of our time. So this is really important stuff, and it's not going to take too long to go over this, but you'll want to know the basic differential for a patient with acute constipation. Okay, if you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or in the I button in the upper right-hand corner. I very much appreciate all the contributions I can get to help offset the cost of these videos, and I thank all those of you who have already donated. And certainly feel free to subscribe to my channel by clicking the little button, and you'll get notifications when I put more and more videos up. So we're talking about constipation here. Now, there are a number of causes of constipation. You should be familiar with the more common causes. So a sedentary lifestyle. Sedentary lifestyle, poor fiber intake, probably the most common cause of constipation. Dehydration, that makes sense. If you're not getting enough water into the intestines, you're going to have harder stools. They're harder to pass, and they can even get stuck and cause a fecal impaction. Iron is a well-known cause of constipation, so look for patients who are on iron supplements, maybe women with menorrhagia, and so forth. There are a number of drugs that can cause constipation. The most famous, or maybe infamous, is the opiates. Calcium channel blockers, iron is mentioned, anticholinergics, antacids, and some pathomimetics. Remember, antacids have calcium in them most of the time. Fecal impaction is mentioned. Hypothyroidism slows everything down as well. Colon cancer can cause an obstruction. And then neurologic disorders. So we're kind of getting less and less common here. Okay, what is constipation? Well, first of all, we need to know how often should you be pooping. And how often is 3 times per day to 3 times per week. Okay, if you're more than 3 times per day, we'll consider that diarrhea. If you're less than 3 times per week, we consider that constipation. So fewer than 3 bowel movements per week. And because they are not pooping as much, water is going to get drawn out as it does. And that's going to result in harder stools, making it harder to pass. And so you kind of have a vicious cycle going on. They may describe their stool as hard or lumpy. I do not use the Bristol chart for stools. I just take patients by their words. So to work up. Now, I didn't get this from a particular source. This is just Dr. Boland's way of working up constipation. So I always get routine labs, CBC and BMP. BMP will help with those electrolytes because electrolyte derangements can cause constipation. Serum calcium, just because hypercalcemia is a big cause. Thyroid function test because hypothyroidism. And an abdominal x-ray where we're looking for the possibility of a fecal impaction. The treatment here is to minimize the offending agents or to treat the underlying cause. When I say minimize the offending agents, I'm talking about try and draw back on the opioids, try and draw back on the iron as soon as you can, and things like that. Lifestyle changes, getting out, working out, anything, doing sit-ups can be helpful, anything that gets the abdomen moving. Coffee, I worked with a gastroenterologist that would recommend coffee as a way of helping move things along. I don't know how effective that is, but she was a good gastroenterologist, so you might take that. Over-the-counter relief can be used as well. Psyllium, methylcellulose, docusate. We usually go with the bulking laxatives first, and if that doesn't work, then we can move on to the osmotic laxatives like lactulose and PEG and milk of magnesia and stuff like that. This is a fecal impaction. So when you see poop on an x-ray, it kind of tends to have this hazy glass ground appearance. So you can see it here and here. Functional constipation is a diagnosis of exclusion. So we've got a patient who's constipated. We looked through all those possible causes, all of those labs. They all came back normal. We're going to call that functional constipation. Another word that you could use, I suppose, is idiopathic constipation. Again, here the symptoms are going to be fewer than 3 bowel movements per week. It is a diagnosis of exclusion, but look for your typical symptoms of constipation. The treatment here, we just go straight to laxatives. And like I said, we want to start with those bulking laxatives. And if that's not enough, we move on to more intense laxatives like the osmotics and the stimulant laxatives. Of course, we want to recommend, again, a high-fiber diet and regular exercise. Now, the big differential, and I see students screw this up all the time, is functional constipation versus IBS-C, irritable bowel syndrome constipation type. Now, it's fairly simple to differentiate these. Irritable bowel syndrome hurts, okay? It's painful constipation. It's not so much with regular old functional constipation. They're not pooping, they may be uncomfortable, but they're not in pain. IBS-C, it hurts. Now, how does it hurt? The pain is associated with bowel movements. So sometimes they may have pain, they go and have a bowel movement, and if it's successful, their pain may get better. Or they may have some severe pain while they're pooping, and maybe it gets better. So look for pain as a prominent feature of IBS-C, whereas with functional constipation, pain's not really a big deal. They may feel bloated, they may feel full, they may just not feel great, but they tend to be okay as far as the pain goes. Now, another way that you can see IBS is if they're having constipation one week and diarrhea the next, and sort of that alternating. That's called mixed IBS, IBS-M. These are the Rome-4 criteria for functional constipation. And so it's similar to the Rome criteria for IBS, but the difference is insufficient criteria primarily related to pain. Okay, now how often do you use these? Not super often, because you got a patient coming in with constipation. You know they have constipation. Well, this one's already checked off. And most of the time they're going to tell you, yeah, my poop is lumpy, or I really have to strain. Well, there you go. Now you got 2. So that's pretty easy. Most patients who are constipated don't have loose stools unless they're taking a ton of laxatives. So you fulfill this. And then if they're not having pain, then you're not fulfilling the IBS-C. Both functional constipation and IBS are clinical diagnoses. We use this criteria. I've got 2 friends who one has IBS-D, the other has IBS-M. And they were just shocked that I diagnosed them. And I'm like, aren't you supposed to not diagnose people without doing a physical exam? We have the Rome criteria. Told them you got IBS, go see your doctor.